Here you can see clearly the 4 types of shock. Before we start, I need you to know our first important difference between the pediatric and the adult population in the shock condition. Children can compensate the decrease in blood pressure, but the adult, any change happen in the circulation or in the blood volume can lead to hypotension, but the hypotension in adults can be cured or managed much more easily than pediatric. But pediatric resist the hypotension as much as they can, but once it happens, hypotension in pediatric population, it means a very critical late sign of shock. So it's considered also pre-arrest sign. So the hypotension in pediatric is very critical, and there are some signs before it. We need to, if you are working in the pediatric intensive care unit, you need to focus on these parameters and monitor patient closely to avoid hypotension to be happen. In fast review of the types of shock, the shock can happen because low blood volume, low blood volume, either because of hemorrhage or dehydration, or because of vasodilatation of the vessels, or because the pumping machine, the heart, not pumping properly, or there is a block in the circulation. We will go in details for each type. First type, the hypovolemic shock. Hypovolemic shock means that the blood volume loss some volume of blood or fluid through hemorrhage or dehydration. And dehydration, one of the critical condition happen to pediatric, and also it is much more dangerous than which happened in adult, because dehydration in pediatric can develop easily to hypovolemic shock. But in adults, there is delayed development if patient not manage it properly, but in pediatric, there is fast development to a more critical condition. So take care of dehydration if you have patient pediatric, especially neonate or low birth weight infant or small child, he got vomiting or diarrhea, you need to action fast to avoid dehydration, which can cause simply hypovolemic shock. If you see in hypovolemic shock, the amount of blood pumped of the heart is low, cardiac output is low. Why? Because the preload amount of venous return, the blood returned back to the heart through vena cava, through the venous return is low. So of course, although the heart contractility will increase, but later on also the cardiac output will be low because the blood volume total is become less. This can happen dehydration, hemorrhage, diabetic ketoacidosis. You have some clinical features you can know detect by them that the patient in hypovolemic condition, like dry mucosa, flat fontanella, especially in neonate, cool extremities, and delayed CRT, capillary refill time. CRT, this is the time needed by the skin to return back after squeezing. This test the physician doing for the extremities or the stomach, he squeeze the skin and wait until to see within how many seconds the skin will return back to its integrity, its normal 2. If it is more than 2 seconds, it means that this body suffer from dehydration. In hypovolemic shock, if I ask you, what do you think is the first management step? And here you can catch many mistakes happen by physician or any healthcare, either also by some clinical pharmacists, that once they realize that the patient in a shock, They will focus on the heart to giving some medication like inotrope or some vasoconstrictor for the blood vessels to increasing blood flow without checking the hydration status of the patient, which cause the high risk of arrhythmia because I'm giving the heart more workload without proper compensation of blood or fluid. So the first management here in hypovolemic shock to restore the blood volume, restore the volume of circulation. If the patient loses a lot of blood and he need blood transfusion or he need fluid resuscitation, I need first to restore the blood volume. After that, I need to re-evaluate the patient, as we will see, to check if he needs inotrope or vasoconstrictor or whatever. Distributive. Distributive shock, this a condition happened by vasodilatation of the vessels. If you notice here in hypovolemic, there is vasoconstriction, but in distributive, the blood vessels become wide, more wide than normal. So vasodilated happens and the leakage of the blood volume and fluid from the capillaries. Why? Because in distributive, like in septic or anaphylactic shock, septic shock because of the patient got pediatric infected and this infection not treated properly, so it is spread to the circulation, causes systemic infection, and these toxins went to the blood vessels and cause vasodilatation and the changes the permeability of the blood vessels lead to leakage of some blood from the circulation which cause hypovolemia also, and this is a tissue not receiving enough amount of blood volume and also organ dysfunction happens. This can happen through sepsis due to toxin or through anaphylactic reaction when the patient receive medication which has allergic type 1 allergy for this medication. You will find that first at early sign warm extremities, then later on you will find it cool. In distributive or vasodilated shock, what do you think is the first management step? Adding more fluid? Okay, yes, I will add fluid, but not more. I will add resuscitation fluid because there is leakage already and the volume will become less. But at the same time, I need to add also vasoconstrictor to overcome the abnormal vasodilatation. This is different than hypovolemic. In hypovolemic, I will manage the patient with fluid only and wait for response. In cardiogenic, third type, the problem not in preload, not in blood vessels, the problem in the heart itself, the pumping machine itself. I have heart failure, pump failure, and of course the cardiac output will be less. This can happen in myocarditis, which means infection inside the cardiac muscle or pericardiac cardiac sac. Or I have congenital heart disease like heart failure or ischemic heart disease like MI, myocardial infarction. Any condition inside the heart prevents the heart from contracting in a proper way. In cardiogenic, as you see, the heart not pumping properly, so the amount of blood ejected is very low, which cause also kind of shock. But the reason here is different due to the heart. So in cardiogenic especially, if I added fluid, more fluid, or if I add fluid with the same rate which I added in the hypovolemic or distributive, I will give the patient a high risk of fluid overload and fluid congestion, overhydration. So we will see this later that in cardiogenic shock, I need to give the patient lower rate of fluid according to and monitor the response after each bolus. Also in cardiogenic, my first management step, not the fluid, but the inotrope medication, which increase the contractility of the heart which called, as you know, inotrope like milrinone, dobutamine, and sometimes epinephrine. The last type of shock, obstructive shock. Obstructive shock, the problem not in the preload or afterload or blood vessels or the pump machine. The problem that I have blockage. I have blockage in the blood circulation. This blockage can happen in lung in condition called pneumothorax or in heart in condition called cardiac tamponade. Tension pneumothorax means some air trapped in the lung prevent the smooth contraction and relaxation of alveoli. Also, in the cardiac tamponade, some leakage of blood volume in the pericardiac subpericardium, which prevent the heart from contracting or relaxation in a smooth way. So this cause like obstructive shock and also can happen in the pulmonary vein through pulmonary embolism. So my first management here, not the fluid, but removing the obstruction. Yes, at the same time, I can adjust the fluid according to the patient condition, but according to each type of shock, I need you to know what is the priority, what is my first urgent step.